topic I choose today is the endo practice with the medically compromised patient. Is like a topic that we always deal with. It's not an easy topic that you can find a one reference. No, there's many topics. The biggest one we have is the dental management of the medically compromised patient is the Little and Filage book. But by the time the book is printed, it's outdated. So each disease has its own reference by its own society, by its own regulations. I tried this lecture to be focused more on relation to the clinical and specifically with the endo practice. So I will go directly to the practical sessions from the background. Some had asked me if I can briefly talk about the analgesics and the antibiotics that I spoke in the previous lecture with the endo emergency. I will just go as a brief, then I will go with the medical compromised patient classification. I chose about 10 of the most common medical cases that we are dealing with during our practice. So this is our life cycle as the endo practice. This is the main cause that we are dealing with, is the bacteria. That bacteria, okay, with the byproduct that will cause inside the canal, which is the infection, will cause a tissue damage to the pulp, and eventually after at the apex, we have the inflammation. We go with the physical property as the rotary files, hand files, and we try to clean and shape the canal. With the medicals or the chemicals that you are using, okay, all of this will cause the tissue damage at the pulp and inside. Eventually, we will have an infection from the bacteria, and all of this will cause the inflammation. That's the inflammation that we have is the periapical radiolucency or the periapical lesion, and that's the inflammation. Chemical mediators, and then we have the exudate. Then that's we have at that time the pain and swelling. Dealing with pain is with the analgesics. Dealing with the swelling is with the antibiotics. Not of the antibiotics going to cure the pain eventually. So each one has its own receptors and mechanisms on how we are dealing with. If you go with the analgesics, as a brief, it's a blessing from God that we have these products. Either pre-medicated, that means we give the patient the analgesics before the treatment, okay? And that patient will come to you and he has much or loaded analgesic in his body. This eventually, okay, will minimize the pain during the treatment. And even though, okay, as an inflammation, will help you also with the anesthesia, okay? And this will level up the success of the anesthesia. Also after the treatment, okay, it will reduce, okay, the flare-up. And that's also a good tip for you, okay? Even the patient still on the chair and still also the local anesthesia is working, before he leaves, you can give him analgesics. By the time the anesthesia has gone away, and the level of the analgesic in his body will start to initiate it. So the patient is fully under protection from the pain before you start, during the treatment, and after the treatment. This is like a strategy or flexible strategy, how you can go with it. We have a patients who are tolerant to the ibuprofen, which is a normal patient that they don't have any medical problems. So the ideal thing to go as a mild pain, you go with the 400 milligrams of ibuprofen. If the patient in a moderate, okay, pain, you might go with the 600 ibuprofen, or you might do a combination between the ibuprofen and the paracetamol. So it's like 400 with the 500. If it's a severe pain, then you might go with the much more higher dose. You go with the ibuprofen 800 and with the paracetamol of 1000. That's a big amount. So he can break between 3 hours. If the patient cannot tolerate the ibuprofen, then the recommendation will go with the paracetamol of 500. If he's in a moderate pain, you might go with the acetaminophen or the paracetamol with the codeine. What's the product that we have in the market? We have Panadol Extra, okay? It's paracetamol plus codeine. It's less than 60 milligram, it's about 15. If you need a more severe, you might go with the sulbidine. That means it's paracetamol plus codeine plus caffeine. But you have to be careful with the caffeine with some medication interaction. Now we don't go with the antibiotics, okay? These are the only indicated characteristic with the patient if you want to go with antibiotics. Fever, malaise, lymphadenopathy, trismus, increased swelling, cellulitis, osteomyelitis, immunocompromised. If you look to all of these, it's all affecting the immune system. It's not affecting the pain. It doesn't relate to the periapical radiolucency. It doesn't relate to the pulp necrosis of any kind. So the only thing that you would go with the antibiotics is the only three categories that you would go with: the acute apical abscess, medically compromised patient, acute apical abscess, systemic involvement that will have fever, malaise, or anything, progressive infection. Patient comes to you and he started to have a swelling. Anything before that, symptomatic irreversible pulpitis or a necrosis or apical periodontitis, you don't need any antibiotics. The thing about the antibiotics, okay, does it go and to the apical lesion? No. That periapical lesion, okay, it doesn't have a microcirculation. So it's an inflammation. The medical or the mediators or the body defense is circulating the tooth. They want to protect the tooth from the spread. The antibiotics cannot transmit and go inside the canal and find the bacteria, just only going in the bloodstream. So when I want or I need to use the antibiotics is when I have a reduce in the immune system. That's the time when I have a swelling. So that time I need to give the patient the antibiotics to support the immune system. It will not affect the apical or the periapical lesion. So whenever I have a patient that doesn't have a swelling, but there is a periapical lesion, you don't need to prescribe antibiotics. This is a study by Baumgartner of many of the antibiotics used, and these are the, he used it with the, specifically with antibiotics related to the endo. So the numbers on the bar, 91 and 100, these are the number of percent, how much these or each one of the antibiotics kills the bacteria. So the amoxicillin killed about 91%, amoxicillin clavinic, which is the Augmentin as a brand name, 100%, clindamycin 96%, clarithromycin 89%, and the least, which is the metronidazole. That's the one if you want to take from all the antibiotics, don't use it. It's a lousy drug. It has the most side effect, and it's the most drug that can interfere with other medications. You might use it, okay, or conjugate it, or you can join it with amoxicillin. It will give you a 100, but I don't need it. Amoxicillin with a 91% is much more than enough. So your best choice, okay, or the first choice to go with is the amoxicillin. If the patient didn't recover 2-3 days, then you might go for the amoxicillin with the clavinic acid. Clindamycin, as the new regulation from the A, it's not anymore the first choice. For the penicillin allergic, it's now the azithromycin. But even though with their recommendation, if the patient cannot tolerate the azithromycin, you can go with the clindamycin. Now, there is a tip or a trick you can use is the loading dose. If the patient comes to you already, there is a swelling. So you might use the loading dose. That means what? You double the first dose. So for the amoxicillin, instead of using 500, okay, you might go with the first dose with the 1,000. For the azithromycin, instead of 250, the first dose, you go with the 500 for the first dose. Then the second and third dose, and later on, okay, it will be the same maintenance dose of 250. Do we need something called complete course? Complete course that people say it's for 7 hours. Okay, I'm sorry, 7 days. No. The dental infection, okay, it doesn't rebound. That means what? If I give antibiotics 2, 3, 4 days and the swelling goes down and I stop the antibiotics, that means the swelling will come back? No. The only thing that will make the swelling come back, if you didn't treat that tooth after later on 2 or 3 months, yes, it will come back because you didn't remove the source of the infection. Source of infection is inside the root canal. It's not outside the root canal. The antibiotics doesn't cure the bacteria outside. We need to clean and shape the tooth, and that's the only thing that will remove the bacteria. So we don't need it. So if the patients come to you, you give antibiotics and there is a swelling, 2-3 days that you saw the swelling is going down, that time you can stop using the antibiotics. When you can change it, after 2-3 days, if the patient is using, like for example, amoxicillin, and the first day was huge, then the second day becomes worse, the third day becomes worse and worse, that time you can switch to a higher dose, going from amoxicillin to augmentin. Now, this is just a brief about the normal cases that we are dealing with, is the analgesics and the antibiotics. Medical compromised patient, it's not about systemic, but anything can change in the way how you treat or you manage your practice. At that point, okay, they are considered treating your way of handling the cases. Let's start first of all, how we can classify those patients. We need a classification that I can say how difficulty, how risky those patients. The best one is the American Society of Anesthesiologists, okay, and they divide it from 1 to 6. Regarding from what? AS1, that's considered as a normal, healthy patient. And we have the second one, which is AS2, okay, which is a patient with a mild systematic disease. And if you consider that group, okay, they look to them as the obesity, if they are a smoker, okay, anything that will make eventually in the future a problem that will lead to go to number 3. But under that category, okay, you have the pregnancy, okay, you have the diabetes, you have the hypertension, but these are the controlled patients. You can deal with them, okay, as a normal patient if they are controlled. Number 3, okay, if they are uncontrolled diabetes, if they are uncontrolled, okay, hypertensive, okay, and eventually if they have a myocardial infarction, they have hemodialysis, renal, okay, now they are in category 3. Some of the cases might jump from 3, go back to 2 if they become controlled. For number 4, okay, and 5 and 6, most of the time these cases or this classification, those patients will be treated under a hospital base. They will not be on any regular way. So most of our cases or medical cases that we deal with in our clinic is from 1 to 3. From 4 to 6, these are a high level that will go to a hospital base. So I'm giving you a question now, Dr. Guezani. So according to the American Society of Anesthesiologists, a patient with severe systemic disease that is not life-threatening, considered what? Number 2, number 3, number 4. خلاص يا دكتور؟
Okay.
Very good. Okay, so they are S2 number 3. Okay, because okay, the patients, they have a disease, but they are it's controlled. Okay, it's not life-threatening. So it's number 2. If you go back to see it. So it's number, I'm sorry, it's number 3, okay? So patient with systemic disease. So it's number 3, okay? That's why it's like you need to go with it. So the idea of the stress reduction protocol, I will not come in this lecture and say to you every time that the patient will come in the morning, you need to bring him, okay, you need to make it short. This is a protocol for all of the medical cases. We take it much more higher, okay, with these cases than other cases. So the protocol or stress reduction protocol for all of these cases, starting by the medical risk, you have to assess the risk going from AS1 to AS6. How much is the risk of this patient? You have to consult with his physician. You want to know the complete history of that cases. You need to know the medication that he's using. You want to use the applications of the things that it might use, okay, or the interaction that you might have. Every day is changing. I'm giving this lecture now. It's updated, maybe it's 3 minutes now. There's a new regulation will come. So we need to go after and see new medications, new protocol. We were practicing before COVID-19 in a way, eventually, and different for sure, okay? After this will pass away, inshallah, that even the infection control, our clinic, it might be changed. Maybe the regular way of using the surgical mask, it will be N95. Everything will be changed according to the situation. Second thing, all of them, you need to bring them in the morning clinic. The early the appointment is the better. Should make them the first appointment to give them space, even for them to come to the clinic. They will sit in the waiting area alone and they have time, space, less traffic to leave early. Vital signs. This should be considered for every patient, healthy or diseased. This should be a regular for every patient. Sometimes we don't know that patient has a problem. Even himself, you might discover things. What's the vital signs that we are looking for? The temperature, we're looking for the heart rate, we're looking for the blood pressure, and we look for the respiratory rate. Now, 2 of these or 3 can be with one machine that you can use it and it give you a reading. You might use it in the waiting area or in the clinic while the patient is sitting. Even for you as a physician or as an assistant, you might use it. Okay, we are under stress. Sometimes you don't know where we are at this level. Pain control. Before the treatment, okay, the type of analgesics that we give during the treatment, using the anesthesia with the epinephrine for all the patients, most of the patients, okay, because you cannot say that this patient I give epinephrine or no, it depends on the case. But we try our best to use the epinephrine and you use the analgesics, okay, to control the pain. If the patient is in pain, that means we have a problem. This is not a stress reduction protocol. It will be severe, okay, and he will be nervous. Going to the next one, okay, it's short session. Try as much to possible, okay, to be less than an hour, even less than 45 minutes to 30 minutes. The shorter is much better. Lastly, okay, follow up with the patient. You want to call the patient later on. You want to make him with the medication when he leaves the clinic. You want to see him, okay, safe. You want to call him the day after. The reception will call him to check on him. You want to see that his medication is to the level that he expected. This is the stress reduction protocol for all of the cases that we are looking for. I'm going with some series of diseases that we are dealing with. So I started with one was just like something that we find it, prosthetic joints. Some say we need to go and cover it. Some have modification the way that the treatment. For the latest that we have, the prosthetic joints, either hip or the knee or the elbow, they don't recommend any prophylaxis. They don't need anything. Okay, we deal with them as a regular patient. They were assuming that there will be an infection that will come from the tooth that will go to the area of the joint, which will make an infection. And this doesn't have any proof. So these patients, the only thing that you might think of is the positioning of the chair, the way how they sit, okay, depend on where their joint is, the limit or the length of the session, okay? Otherwise, those patients doesn't require anything, okay? So deal with them as a regular patient. Hypertension, okay? This is the silent killer that all of us, young or even old, we should be aware of it. Don't mislead this thing. All of us under stress, okay? Lifestyle, the stress of expense, the stress of life, taking care of people. So this is a serious disease, okay, that we are not looking after it. I wish everyone in-house in his clinic to check, okay? You don't want to wait for the problem. If you have a headache or any sign of fatigue or anything, just check it, okay? The normal, okay, and the pre-hypertension. Pre-hypertension is alarming for all of us, okay, that you should be aware, okay? Life doesn't worth it, okay? We're under stress most of the time. Just be realistic, okay? What is really caring or what you really need to do, just do it. Stage 1, okay, that patient, if it's come to you as an emergency, you might deal with him, okay? but as a precaution, an emergency case, but you have to send him to the physician. You can be the first line, okay, to alarm that patient, okay, that you have a problem. You need to go and check. So we are also first line to make a diagnosis or a screening for a patient. Patient with a stage 2 hypertension, that should not be touched. That should be under an emergency in the hospital base to reduce the hypertension. If the patient is now taking medication and he still have a stage 1 hypertension, okay, that one patient maybe is not using the medication a proper way, or he needs also to go back to his physician to check with what's the problem with that medication. Pre-hypertension patient also, they are risky patient. Even, okay, for the treatment, you should be aware, okay, to use the stress reduction protocol. One thing also can make this category, okay, misleading, that there is something called white coat hypertension. It's really a science, okay, from the point that it's available, okay. White coat hypertension is someone who's afraid from the physician or the doctor. So most people, okay, the white coat hypertension, when they are sitting in your chair, okay, they have elevated blood pressure, but when they are outside, they are normal. White coat effect, it's much more worse. If he's in the house and he's just thinking of you, okay, he might have elevated blood pressure. And that's a serious problem, because if the blood pressure can go from normal to abnormal, okay, that way of a speed going up and down, it can affect him as a stroke or whatever it can happen in the future. The worst thing is the mask hypertension. The mask hypertension is a patient who comes to you and you check him is normal, but outside is abnormal. And that's the one that you have to always make or push the patient to use every time, okay, blood pressure, to use it, okay, sphygmometer at their house, to regulate and to see what will be their lifestyle look like. If they're obese, okay, if they are on a, like not a healthy food, or they are under stress of their work, to take a vacation, whatever, okay? But all of this one is what we deal with. I will go with each disease, and I'm not going with the mechanism of the disease. I'm going only to give you the tips, okay? Of which one you like or which one is preferable to use with each disease. So hypertension, local anesthesia. The problem with the local anesthesia, okay, that the epinephrine and the local anesthesia itself can make the non-selective beta blockers, okay, may increase the local anesthesia toxicity, okay? So can we use it with epinephrine? Yes, okay, and we should, but we have to reduce the amount, okay? And we have to increase the time interval. So if I'm giving now a local injection, I cannot give the next one after a few minutes. I have to wait 10, 15 minutes. How much I give? This one I'll talk in detail in the cardiac patient, but make sense or make your own mind, this number is 0.04 milligram, okay? This is the maximum number of the epinephrine you can give to those patients, but you should give, okay? For a regular, okay, local anesthetic, okay, you might give a 2% lidocaine with 1 to 1,000, okay, epinephrine. That means the 2 maximum is the 2 injection. If you're going with the 1 to 2,000, it might go for 4 injection. I will talk in detail about how you can measure these things. So local anesthesia, yes, you can go with a maximum of 2 if it's with the regular, okay, that means it's 0.04 milligram. For the analgesics, okay, makes sense that the NSAIDs, okay, like the ibuprofen, okay, should not be used. The safest that we use is the paracetamol, okay, the acetaminophen. So this is the base or the best thing you can use with these patients, either normal, okay, or the pre-hypertensive. Going with the antibiotics, okay, does it have any effect of the antibiotics on the hypertension patient or the medication they are using? Yes. The macrolide antibiotics like the erythromycin, okay, that's increased and prolonged, especially with the calcium channel blockers. So the recommendation to use with those patients with the hypertension, going with the penicillin antibiotics. So if we want to summarize it, okay, local anesthesia, yes, you can go with the epinephrine. The maximum is 0.04 milligram. If you want to go with the analgesic, you might go with the best thing is paracetamol, okay. If you go with the antibiotics, you will go with the penicillin. You have to check the patient, okay, before and after for every patient, okay, not only hypertensive patient. Make it like something regular in your daily practice. Cardiac disease, if you go with that diseases, we have the American Heart Association. The American Heart Association give these only the condition that will require the antibiotic prophylaxis. Prosthetic card valve, previous infective endocarditis, congenital heart disease, and cardiac transplant. These are the only categories from the American Heart Association which require antibiotic prophylaxis. This is the regiment. Now, the thing about the American Heart Association, they didn't change the recommendation as the American Endodontic Society recommendation of the clindamycin ever talk about it. So it's still the same regulation till date 2020. It's the same thing. So you go with the 2 gram, okay, for the amoxicillin, okay, and we might go with the American Endo Society from that point, because what's the problem with the clindamycin? Clindamycin, the FDA, which is the Food and Drug Administration in the US, puts a black label on that box of the clindamycin, say it's called colitis, and it will cause a fatal, problem for the patient. So you might go with the first choice, azithromycin, 500 milligram. This is the antibiotic prophylaxis, and it's all the prophylaxis that we will have in the coming disease. So whenever I say that patient will need a prophylaxis, it's under this type of medication under the American Heart Association recommendation. We need to know the drugs, although it's not our specific field, but we need also to be educated in that point. The anticoagulant and the antiplatelets. Now we have the drug classes. Now the antiplatelets, it's like the mostly known, okay, is the Plavix, aspirin. These are the antiplatelets, and it's working on platelets. Anticoagulant that we know is the warfarin and the Coumadin. Now, some patient or some physician, okay, they want to know when I can stop the drug. You are not in a position to stop any medication. You're not the one who prescribed these medication. It's a physician and cardiologist who knows what he's doing. The same thing as you are an endodontist, you know what you prescribe for that patient because of your specialty. But you need to know this medication, that which one will interfere with your medication. You cannot stop any medication. You cannot stop any drug. Some patients, okay, they are not cardiac patients, and they are taking like aspirin as some prophylactic or just as a preventive. Some they use it above the 50 or 40s as a preventive. Say, okay, you cannot say to the patient, stop that medication if it's prescribed, because even though, okay, the bleeding from that medication is not too high, it's not bleeding, it's taking a longer time to bleed. Even though the aspirin, okay, if you want to stop it, okay, and you want the platelets to be back to normal, okay, 3 days is not enough. You need 7 to 10 days, okay, to make the platelets back to normal. Although the antiplatelets in general, okay, you don't have to stop it at all. Our problem is the anticoagulant, the warfarin. It's the most lousy and the most headache drug that interfere with all medications. There is recent now medication that's called direct-acting oral anticoagulant. These medications are go specifically and directly, okay, to the point that they want to do their action. The warfarin, okay, it goes to many systems and many processes, okay, to do the work. So it interferes with every process, interfere with all medications. So the direct-acting anticoagulant, it's a promising medication. We don't have enough studies about it, but it's a promising. Even those patients who are taking it, they are taking it with no monitoring, okay, of their physicians. It's very safe. Even the INR, they don't check it from time to time, but also as us, if it came to us, we need to check the INR for those patients. But it's safer than the warfarin. It's less complicated or interactive than the warfarin. So for the cardiac disease, okay, to be dealt in a dental practice, the first thing we want to know is what we call the INR, the international normalized ratio. This is what I want to see, the effect of the anticoagulant, okay, inside the blood. I want to see. No, the normal INR range is 1. This is the average, is 1. to be accepted or to work in an environment that you might, with all or most of our work in the dental field, we need the INR to be from 2 to 3.5. 2 to 3 is a very safe, that you can work with everything. Surgery, okay, is the one we have issue with that. You don't want to be at the border of the 3. You want to be closer to the border of 2. You don't want to go below that number, because that's two things that you have to put in mind. You might have some more bleeding, but you can control the bleeding. But you don't want the patient to go below to closer to the normal, because that patient might have emboli, he might have stroke, they might have a heart attack. So you're measuring two things, life safety, or you can just go and you can do the blood clot. So we want to be 2 to 3. This is the average. We want to go 2 and 1.5 to this level, okay, for a surgical, and to the max 3 to 3.5, whatever procedure you want to do with the endo treatment. When you should, or you ask the patient to know that, it's the day prior your endo treatment. So the patient, okay, came to your clinic and you were doing extensive procedure, something will need surgery or whatever, yes, you need it the day before you know the result. But someone who's doing something routinely, or just a normal, okay, root canal, a week before or 3 days before, it will not make a big difference. So the result will be the same. But you will not request someone who give you the result a month before, because the INR is not stable, okay? So sometimes food things, okay, or some of the medication habits may change the INR. So this is the guidelines, okay, for most of these patients with the stable patient, okay? Now, where we have a problem, then we have the angina, or someone who have myocardial infarction, less than a month. That's unstable. If you want to treat this patient, you need a hospital base if they need an emergency. Going from 1 month to 3 months, okay, still with the semi-stable. Above the 3 till 6, we are in a good condition, and we can go to the first slide where we need the INR and check the medication and check how this patient can tolerate our treatment. So below 1 month, okay, that's risky. Above 1 month to 3 months, acceptable, but you need to also to consult with his physician. Above 6 months, you can deal with him as a regular patient. You can go with the INR, check his medication, and you can do the treatment that you go for it. Local anesthesia. This is the slide where I want to discuss how we can measure the amount of epinephrine. It's the same calculation as it is with the hypertension. So we have this number, 0.04 milligram. This is the max you want to use with those patients. Equals to what? It equals to 2 cartridge of 1 to 1,000 epinephrine, or 4 cartridge of 1 to 2,000 to 100,000 epinephrine. Now, this type of equation is wrong. We always write it in a wrong way. You need to know how the capacity of the carpule, how many milliliters, okay? And you need it to be by milliliter and milligram. This is just a standard, okay? Because in the market, okay, we don't have the same carpule every time. You will be surprised there is 1 milliliter, there is 1.7, and there is 2.2. It's different inside the content. You need to know the medication by milligram. So let's go for an example, okay? The most common we are using, it's 2% with 1 to 1,000 epinephrine. How much it's equal if the normal carpule, which is 1.8, okay? It equals to 36 milligram, okay? If you want to know how much is the 1 to 1,000 epinephrine, it equals to 0.0118, okay, milligram. So how many I can use to reach to the number that I want to reach to is 0.04. It's 2 carpules, which will equal to 0.036, okay? That's a maximum, so you can use 2 carpules. If you're using, okay, something with the 1 to 2,000, okay, it will equal to 0.009. That means I can use 4 carpules, okay, of 2% of 200,000. So you need to know how much is the carpule, okay, the milliliter, okay. You want to know how much is the epinephrine inside. On the other hand, if you are using the 150, okay, which we don't have in the Saudi Arabia, maybe 80. But if you are using, for example, the 150, okay, you can use only 1 carpule for that cardiac patient. So you want to know how much is the milliliter. You want to know how much is the lidocaine, and more importantly, how much is the epinephrine in milligrams to know that number equals to how much in 0.04 milligram. For analgesic, which makes sense, okay? Non-steroidal, okay, inflammatory drug is prohibited, okay? You need to go with the paracetamol, okay? Because these drugs, okay, will interfere with the anticoagulant, which will increase the bleeding. So the paracetamol is the safest. When we go with the antibiotics, yes, the metronidazole, which is the worst thing, that's the one directly go and antagonize the warfarin. Macrolide, okay, antibiotics like the erythromycin also need to be stopped. Penicillin is the best choice. So if I want to summarize the cardiac patient, okay, you need to be stable condition. You can go with the analgesics, maximum is 0.04 milligram. You want to go with the analgesics, it will be with the paracetamol, okay. If you're going with the antibiotics, the penicillin is the best choice. Now, regarding this case, okay, or the cardiac disease, I added, because I want something related to our profession. We have the pacemakers, okay, and the defibrillator. Many argument, okay, with our machines, with our equipment in the clinic. Does it interfere with that? But we have to differentiate, because there is two things or devices in the market, okay, or the profession of the cardiologist. The pacemaker, okay, it's both of them under the skin, and they have like a wire go all the way inside the heart. The pacemaker, okay, is work like a signals. It controls the rhythmic of the pulse of the heart. While the defibrillator, it's much more complicated, because it can even change, okay, and defibrilize the heart if there is any shock or anything. It sends like a shock. So it's much complicated. Both of them are programmed, but the defibrillator is much more complicated. Now, for a good study, okay, that had been done, okay, and this is a vitro study. They tested, okay, many of the equipment that we are using. Curing light, electric pulp tester, electric motor, gutta-percha heater, electric apex locator, and electrosurgery unit. If you look to the design, okay, this is only on the defibrillator and many brands, okay? And if you have something here called EMI and EMD, the EMI is the electromagnetic interference, and the EMD is the electromagnetic disturbance. Now, the majority, okay, of the sonic and ultrasonic devices and the one with the waves, they have interference. The interference of the machine doesn't mean it will affect the function, okay? So it's only interfere, but it doesn't change the function, okay, of the machine. The worst thing, if you have EMD, which is the electromagnetic disturbance, that means it disturbs the function of the machine. Among all of these, okay, the pulp tester and the gutta-percha and the other things is only just an interference. The worst thing is the electromagnetic or the electrosurgery, okay? That's the one should be avoided. Avoided to be used with the patient with the cardiac pacemaker or the defibrillator. One thing, because I couldn't find any way to put in this lecture, if some people they are using the cochlear implant, someone who has a device to be added to the head, okay? Electrosurgery is prohibited. It might interfere, but doesn't disturb by the ultrasonics. This is a good study. That's in vivo study, okay, where they used, okay, a battery operated curing lights, ultrasonic bath, ultrasonic scalers, electric pulp test, and electronic toothbrush. Now, with the result of this study, okay, they didn't observe any significant clinical interference. There is interference, but it's not affecting the function of the device. So, as a conclusion, is the devices are safe to be used with the defibrillator or the pacemaker? It should be used with caution, okay? That those patients, okay, don't use it for a longer time, don't use it with the high frequencies. You have to check with the manual. Each one has a device they have and a manufacturer, because these studies had been done on specific brands, which the brand, each one is different from the other. So you need to check with the manual of each device. You want to see the precaution, okay, that had been used. Try to minimize as much you could, but still, it can be used, okay? It's not prohibited, you still can use it, because these are tools that the ultrasonic, we cannot remove or take it out from our practice, because this is one of our tools to succeed in many cases, especially with those cases that all the elderly patients, calcified canals. You can imagine you can live or work without these patients. These tools, you need them. So use it with a precaution. Going for the bleeding disorders. There is many diseases. You can have a one lecture on hemophilia, okay, but try to make the precaution and the protocol that will make for all the disease. The problem with the bleeding, okay, or bleeding disorder is not they bleed longer, no, but because the bleeding factor or the timing, okay, takes longer. They are not oozing, okay, no, but they need more time to clot. So those patients, okay, you should be aware, okay, infiltration, anesthesia with epinephrine. That case you have to, because it's part of the hemostasis. The interligamentary and intraosseous is recommended over the mandible. You cannot use, okay, inferior alveolar nerve block or use a lingual filtration on the floor of the mouth with a patient of the bleeding disorders. You can go with the buccal infiltration. You might go with the intrapapillary or intraosseous. You might go with the interligamentary. 80% of the time, if you did inferior or do an or lingual infiltration, 80% you might have a hematoma. That will cause suffocation, blocking the airway. That's a life-threatening. So for the normal treatment for those patients, you can do it in your office with the infiltration. If you need to go with something in the mandible, you go with the intraosseous, okay? If you need to do a surgery, now that's a problem, because that's a problem we need to do something factor replacement. Something like hemophilia A has a problem in factor 8. Factor 8, okay, you need to do it as a hospital base. They need to inject or provide that factor so the bleeding time will be less, so you can proceed and finish your work. For those patients, which makes sense, analgesics, aspirin is the worst thing. You will never use it because the aspirin is antiplatelet, so the aggregation of the platelets will not work. So NSAID and aspirin should not be used with those patients. Paracetamol is the recommended analgesics for those patients. Going with also the antibiotics, okay? It's still safe. So I'm trying to give the recommendation for each disease, for each category, okay? To the point that it will help you in the clinic. The mechanism is different. Hemophilia A, B, C, Van Willebrand, okay, platelets disease, all of this will need a category, but you still can manage them in the clinic according to the minimum criteria that you have. If you have something extensive, okay, then you need a hospital base and consult with the physician. Now, going with the anemia, okay, the anemic patient in general, okay, weak, fatigue, okay, those patients, okay, do not have a big problem with our clinic from the point of the medication we are prescribing. But we need to make them okay. Early morning, they are taking the food, the position, okay, sometimes they need something near to them like sugary things inside. But there is one specific anemic condition related morely or mostly to us as an endo, okay, mostly the endo. It's the sickle cell anemia. Sickle cell anemia has a tendency of pulp necrosis with clinically intact teeth. That when you say intact teeth, that means, okay, no filling, no decay, nothing. 8 times higher than a regular patient. The pulp necrosis in these cases is much higher. The reason why, because it's from the same disease problem. The hemoglobin is like a sickle. The body is attacking those cells, phagocytosis, those cells. Second thing, okay, that the same design of the sickle, when it's enter or pass the apical area to reach the pulp as a blood supply, it aggregate and it close the apical area. So it stops the blood supply to the nerve. So you have a pulp necrosis in these teeth. So a patient comes to your clinic who has only a sickle cell anemia. He has a pain in his tooth. You check and you saw a lesion. And you examine, there is no disease or no decay of any kind. Always put your mind, okay, sickle cell anemia has a tendency for these cases. Also, for those patients, you need to do a regular checkup. If you came for a one tooth take an OPG and check the other teeth. Those patients should be on a regular basis recall to check the teeth, okay, check the vitality, accessibility, all of the kind of the treatment. Aggressively, they should be cleaned and shaved because they are prone to infection. So this is in your mind, sickle cell anemia and the pulp necrosis. Asthmatic patients, okay, the problem with them, okay, that they need, especially the active asthmatic patient, they need the inhaler all of the time they were to have it in their clinic. Macrolide NSAID should be avoided because it's also aggregate the asthmatic and the medication itself. Penicillin and paracetamol, okay, it's the drug of choice. Although some say the lidocaine with the sulfate or whatever the component might interact with the asthmatic patient, but there is nothing proven so far. You need with those patients to be very careful that you don't initiate the asthma, okay? Because when they started, okay, and you are using rubber dam and everything and on the chair, it will be a hell of a time. So you try to avoid always the suction. You don't want them to be like having any cup of any time or on the session. Pregnancy, which is the most common hot topic, okay? No one treats pregnancy. She's pregnant, okay, and wait till she deliver. No, because the problem with the pregnancy is not the pregnant himself. We are dealing with two patients, and that's the issue, okay? We try to avoid the first trimester. Why? Because it's the developing stage of the fetus, okay? We don't want to have any intervention with that patient. But if it's really unnecessary, we can go and do it, okay? Yes, it's the highest abortion in the first trimester, but if the patient in pain, okay, we can go and do the pulpotomy, pulpectomy, all the procedures, okay? It will not make it. The worst thing that you only prescribe the patient the antibiotics, prescribe the analgesics, okay? This is what will harm the fetus development. We can push it to the second trimester, and this is the ideal trimester for those patients. You can do whatever you want in that case. Do it safely, try with all the treatment that you want to do with the patient. Now with the third trimester, yes, you can treat that patient, but you need to be cautious because you need to make the visit short and you need to make the chair position is different. It's not the chair itself, but the position of the patient, how she is sitting on the chair. You need to make her go on the left side, lift her right over the left leg, and you can place a blanket underneath her, okay, or you can push her all the way on the other side. Why? Because at that stage of the third trimester, okay, the fetus is big, okay, and there is a heavy, okay, pressure from that side on the inferior vena cava of the patient. And that, if it stays for a long time, it can make a deep vein thrombosis, okay? And you want to avoid that. Just push the patient on the other side, okay? Make it a short visit and be careful, okay, to make her, okay, go faster from the chair. But you can do all your treatment. There is no precaution from any kind of the medication to go and use it. The radiation. Do we have any problem? This is a statement, a LARA, that should be used with all patients, not only with the pregnancy. What's the simple is as low as reasonably achievable. And that's why, or how we can achieve it, is by the time. The lesser the time, the distance should be a little bit far. Shielding, which is using the apron. This is the way how you handle it. Can we use it with a pregnant lady? Yes, we can go and use it. We are using the kilometer, okay, and we go on focusing the beam of the X-ray to the patient, okay? We're not beaming it to the fetus, okay? So the pterogenicity, which is like the mutation of the gene, okay, in general, we are saying about 0.0001% to have it. Yes, it's a percent, but it's not affecting the treatment. I'm looking for the quality of the patient. I want her to come back, okay, because of a tooth pain. Fix it, done, she will deliver. That's the whole thing. They're using many medication, many analgesics, many things, put in the chair, but because you don't want to use the X-ray, okay, that's the harm for the patient, okay? So you can use the X-rays. Use it with as low as reasonable, achievable. What's the type of medication we can go with the pregnant lady? We have to follow the FDA category. The safety, okay? We want to be mostly at the B, okay? At the B category. For the antibiotics, okay? Amoxicillin is our first choice. It's B, can be used during the pregnancy or during the breastfeeding. Okay, we can go with the analgesics as acetaminophen or paracetamol. Yes, both can be used pregnancy and during the breastfeeding. With the local anesthesia, okay, we can go with the lidocaine, okay, and we can go with during and after. These are a safe drug. I try to make it very simple to be in your mind. In all the medical compromised patients that we came through, you can find lidocaine is in all categories, acetaminophen in all categories, the amoxicillin in all categories, okay? So something that you put in your mind, you not be afraid to treat a medical patient or a medically compromised patient, but you want to know what's the situation and what's the progression and how I can deal with it. This is for the pregnancy. Going for a diabetes, okay? That's the most common that we have in our country, okay? So the diabetic patient, we can deal with him as a normal patient, okay? He doesn't have any special way of treatment. We always look to the fasting on the blood glucose number. But the more important is the HbA1c test, okay? And we need it to be 7 and below. That we can deal with him as a normal patient because all of the organs or the systems, okay, will be within normal, okay? The worst thing that you have is uncontrolled diabetes. This will have, and it's clinically proven and scientifically proven, is delayed in the healing, and eventually, okay, they have susceptibility of infection. Those patients with diabetic or uncontrolled diabetes, they are the most cases that you might have inter-appointment emergencies. Okay, they will have more tendency to have a failure, even a longer time healing. So you have to put in your mind, first of all, you have to control that patient. Okay, you have to go to his physician. The implant physicians, okay, the implantologists, they don't treat patients if they have something with the diabetes because they know the success in the bone. So the same thing for us is the healing, okay? We look after it. You cannot wait for 1 or 2 years, okay, for a normal patient and you expect the same thing for uncontrolled diabetes. You might have a high tendency for failure. It's not because of you as a treatment, because of the patient. So there is something from the patient side have to be controlled. This is a good study, okay? And it shows, okay, how the interrelation between the endo, okay, bacteria or the endo infection and the diabetes from the other side. We have the infection and we have the lipopolysaccharide and we have the immune system. All of these chemical mediators are affected by the healing that it's affected by the diabetes. If the diabetes is not controlled, then all of our healing process, okay, it will not go. It's a cycle, okay? Any of these, okay, uncontrolled diabetes, then we have a break in that cycle. If we have a prepuccal infection and we have a controlled diabetes, we will have much more higher success. So we have to control the disease more than to look how we deal with our clinic and that patient. Because uncontrolled diabetes, they are prone to have hypertension. That hypertension will lead to kidney failure. Also, they have a vision problem. So it's a sequential, okay, of things that you have to put in your mind with dealing with those patients. Renal disease, we have 3 common things. Chronic renal disease, those patients who have a functional kidney, maybe 1 kidney or both are working, but they have less functional working. Those patients, I need to use less nephrotoxic drugs like tetracycline should be avoided. Antibiotics like amoxicillin, analgesics like paracetamol can be used. They could be used as a normal patient, but even though the time interval or whatever, you need it to be less. But those can be dealt as a regular patient. You need to give them antibiotics. You haven't seen in all of the diseases before I said any antibiotic prophylaxis except the cardiac, okay? Maybe we can go with uncontrolled diabetes, okay? If it's really heavily uncontrolled, I might go with it. But with the chronic disease or renal disease at this stage, no. When you can go with the renal disease to do the clinical, or you can use the antibiotics prophylaxis, if they are on hemodialysis, not all hemodialysis, because those patients, okay, you need to see them, especially who are doing hemodialysis, you need to see them the day after the hemodialysis, okay? Why? Because their body is washing out from the heparin. During the dialysis, they're using heparin, okay, and that's you want to make it less during, okay, for the coagulation. If the patient using the protein or what protein on the type of the hemodialysis that doesn't have any piece on the hand implemented inside, okay, you can go with the normal procedure. But if the patient have something intravenously invented, okay, or inside the arm of the patient, you need to go with the antibiotics prophylaxis, the same as the American Heart Association prophylaxis. Going for the worst thing, okay, and you can see here there is no recommendation of any type of analgesics or antibiotics because the patient is washing out all the toxins. So no problem, you can use whatever you want with these cases because they are taking it out during the hemodialysis. Going with the renal transplant, someone is doing a renal transplant, you don't want to touch that patient in the first 6 months. Usually with those patients, if they want to go with the hemodialysis or the renal transplant, before they go for that, they will go and check up and do all their teeth, all the physician before they start and go for operation. So very few times that you will have a patient comes after the implant or during the renal transplant, and they should be avoided, okay, because they are taking an immunosuppressive drugs, okay. Those patients will need a prophylaxis before and after, during, even though most of their life, because they're taking drugs that can depress the immunity to keep that organ, okay, accepted by the body. So those will need to be used, okay, and to use antibiotics prophylaxis. If the patient's taking hemodialysis with the AV shunt inside implemented, they will need antibiotics prophylaxis. Otherwise, a normal kidney patient who has only a kidney problem, just only you reduce the amount of medication that will be nephrotoxic to the kidney. That's it, nothing more, nothing less. Hepatitis patient. What's the problem with the hepatitis? The problem with the hepatitis is that all of our medications are metabolized or in the liver. So it's the factory that all the manufacturer give the medication that will transfer and it will go all the way till it reach to the kidney, to the liver. That liver, okay, is the one which will control the toxicity of the drug. Then after that, it will just send it to the organs. If I have a problem with that organ, which is the liver, okay, it's not the liver cirrhosis, I'm talking about hepatitis, okay? So the hepatitis as a disease should be controlled. Most of the patients, when they come to you, they are a carrier, so you have to be careful. Does that mean the patient can transmit the disease to you? It can be, so you have to be all patient to deal with them that if they have a disease or any kind of infectious disease. Especially now, after COVID-19, all of us should be aware of all type of infection control. So for the analgesics, okay, the NSAIDs, okay, should be avoided. Now, paracetamol is completely fermented by the liver, and that's why it doesn't produce toxins. So the most I can take from the paracetamol, okay, it will be fermented by the liver, okay, no toxins will come after that. So we can use the paracetamol in those patients with a larger, broader spectrum, okay, of timing. You cannot go say, okay, after 3 hours, you use it again. No, let's say for 4 to 6 hours. But this is the safest to be used with the patient with the analgesics. With the antibiotics, okay, erythromycin, metronidazole, all of these ones should be avoided. Ampicillin, okay, is the one can be used. And that's the least, okay, can make it damage. So this is the only difference from many of the other medication or other condition. The ampicillin is the recommended antibiotics for the hepatitis patient. Going with the malignancy or medicated, okay, osteogenic necrosis. So many people have talked about this topic in the past few weeks. I'll be more specific. We are having a problem with the osteonecrosis of the bone. So most of these patients, the same thing as the renal transplant, they will come to you before they have chemotherapy, okay, to make clearance for all teeth. They will do all the treatment. So few of the time that will come to you during the treatment. We may need only to be focused on two things: the type of the route or the way how this patient is taking the medication. If he's taking an IV, okay, or he's taking an oral. If he's taking an IV, That's the worst one, because those patients, they have a higher risk of developing the necrosis of the bone, okay? Those patients also has a higher risk of developing those situations. We try to avoid any surgery on those patients. So even those cases that you might have a tooth, which is badly broken, non-restorable, they will avoid to go for extraction. They might send it to you as an endo, saying do a root canal for that tooth, just clear the infection and just temporize it with something solid or fine until we finish the treatment. Then after that, we go for another treatment like implant or whatever they are going for. So you are the least, okay, damaging for those patients to go for surgical. So you will not do surgery, epical kinds, extraction, no. You want to make a clearance. You want to clean the infection. You want to clean that tooth. You want to clean and shape that tooth and close it, okay, for those type of IV. This is the worst thing if you have those patients. If you have a patient who's taking the oral bisphonate, they are less problematic, they are less infectious, they are less having a problem with the medications. So they are mostly safer than the IV. HIV. Now, all of these diseases, we deal with them. Some people say, okay, we don't know why you are talking about HIV. We have HIV patients among the community, okay, and they are part of our society, okay. It's not a negligent people, okay, that we should not treat them. No, they are a human being, okay, need a treatment, okay, and you cannot avoid them. Now, for the problem with the human being, the HIV patient, the treatment has lesser prognosis because of the problem of the virus itself, the HIV virus. It affects the T cells which is affect the phagocytosis of those cells. So the CD4 of that condition, we need to see the count of the CD4. If they are higher or lower to go with that patient. Some of the interesting thing that you can find HIV in the pulpal, okay, tissue, okay, and you can find it in the granuloma, okay. So you have to be careful, okay, dealing with all patients. The number, okay, or the incidence that you might have a blood, okay, or a contamination you might have transplanted from the HIV is very less, okay. You will not be afraid, okay, to have that problem. So you deal with them. Even if you ask me, okay, COVID or HIV, I'll say HIV, it's much more safer in the point, okay, of the transmission, okay. Can we not treat those patients? Legally, you cannot refuse to treat those patients. You have to deal with them. You have to treat them. This is a part of your responsibility as a physician. You have to deal with them and you have to treat them. You have all the regulation, you have all the measures, okay, to go and deal with those patients. The emergency drugs, okay, this is something that you have always in your clinic. I will keep this slide for sometimes you want the shots, okay? Adrenaline, aspirin, glucagon, glucose, glycol, okay, midazolam, okay? This is the emergency medications and the routes and the doses that you need to go with and the indication. You have to make it updated. You have to make it also check the expiry. You have to make everything in hand. Some of them, they have it like in each case, okay, in each drug, because some of them have half-life, okay, morphine or whatever, okay, 6 months or less. You have to be careful from the expiry of this emergency drugs in the dental practice. After all of this, okay, does the endo, okay, or the dental is very infectious and we cause a bacteremia and we are in a source that we are transmitting diseases and we introduce it to the patient? This is the conclusion, okay? But after that, let's see the question number 2. How much do you think the bacteremia can be introduced by the endo procedure? Okay, doctor? Okay, very good, okay. It's 20%, okay, which is very good that you can say it. 40% is too high, okay? I'll show you a slide, the last slide. This is the frequency of bacteremia, okay, from most of the dental procedure that we have. Tooth extraction, 10 to 100%, which makes sense, okay, because we are dealing directly with the circulation. Periodontal surgery, and that's the one I might put the apical surgery with that consideration. So I might have 80% from that. Scaling, root planning, also 80%. Prophylaxis. Rubber dam, okay. Wedge placement, 32%. Look to the endo procedure. We don't introduce bacteremia, okay? All of this myth on so much of our procedure. If you're doing it in a correct way, rubber dam, pulp exturbation, cleaning and shaping, and everything will be fine, okay? Can you imagine that the wedge placement is much more bacteremic than endo, okay? That's the real life, okay? So you should not be afraid. You should practice well, update yourself. All of us have the phone, there is many applications to check the medication. You might look what the best book that we have is the Dental Management of Medically Compromised Patient by Little and Filage. It's the 9th edition. You might go and check with the each society. Don't only rely on friends or of website. Go to the American Heart Association, to the American Joint, okay? All of each one has a specific relation. The good thing also about the ADA with the American Dental Association that they always make an update for each time. You will have a source of lectures and the pamphlets and the cards and the ADA website for all the references, all the literature. Everything you can find it there. Thank you very much. I hope I was concise, straight to the point. I want to make it pointy, clinical part.